Download the DigiShield app from the Play Store or App Store now. New users will go through a quick one-time registration process. After filling in some basic information, registration is complete and you can start using DigiShield. Logging into DigiShield is easy, safe and secure. Enter your registered mobile number. An OTP is sent to your mobile. Enter the OTP and you are logged in. No passwords to forget. Making a patient's appointment is easy. Just click on the calendar sign, enter the patient's name and mobile number. Select date and time of the appointment and that's it. A confirmation message will be sent to the patient and so will a reminder. A day before the appointment, your patient will be automatically contacted by the DigiShield agent. The Shield agent will collect the patient's symptoms, history of present illness and more. The agent will also collect any consents or indemnity that you want to collect from them. Based on the DigiShield interaction, you will be alerted to the patient corona carrier risk. It's easy to do a phone or a video consultation with the patient. DigiShield recommends that patients that have been flagged with a high or moderate corona carrier risk should be consulted via consultation first. Click on the phone icon or the video icon to do a safe and secure teleconsultation with the patient. In order to issue an e-prescription to a patient, tap on the pencil icon, tap on the camera icon to take a photo of the prescription and you're all set. The prescription is sent securely to the patient immediately. DigiShield is easy to use and you will be online within 5 minutes of downloading the app. Download DigiShield on the Android Play Store or Apple App Store today. Protect yourself, your patients, your community. Download DigiShield for free today.
Hello.
Yes, sir.
Hello. I am on Zoom now.
Yes, sir.
Thanks, Rajiv. Director, David Global Life Sciences Private Limited, cordially invite all the eminent doctors participating in MASTACON 2020. I started my pharma career 31 years back from Sholapur, and I'm very happy to be a part of David and back to my Karmbhumi after so many years. David serves all doctors who have fought valiantly against the deadly pandemic coronavirus and saved so many patients. David wishes MASTACON 2020 a grand success and happy learning to all of you.
Hello. Hello. Hello.
Yes, sir. Please wait for the video to be finished.
Established with a focus with quality compliance and regulatory compliance, not only for the domestic market. It is going to be international company taking forward their medicines for US, Europe and rest of the world markets. Because of this COVID pandemic situation, pharmaceutical sector is on global focus, and the quality compliance and the regulatory compliance is the prime focus for all the patients where they are consuming the products. And that's what actually means David means quality. That's what actually our motto is.
Hello doctors, we congratulate IMA Solapur branch for organizing such a wonderful virtual conference for the first time. We at the WIT believe that everybody should have access to quality medicines. Therefore, we manufacture our products at world-class facilities. And not only that, we manufacture our products using modern technologies and we analyze our products using advanced instrumentation like GLP and GLC. We introduce creative branding solutions and marketing solutions to help you provide wide range of therapeutic options to your patients. We launch and promote most accepted and widely used therapeutic molecules. And we keep on adding new products as per the therapeutic gaps. We also launch products with product differential as well as in-licensing products to provide you with more therapeutic options. Doctor, as you know, the journey of 1000 miles starts with a single step. Today we are taking that first step. Thank you so much. Have a great time at conference.
Download the DigiShield app from the Play Store or App Store now. New users will go through a quick one-time registration process. After filling in some basic information, registration is complete and you can start using DigiShield. Logging into DigiShield is easy, safe and secure. Enter your registered mobile number. An OTP is sent to your mobile. Enter the OTP and you are logged in. No passwords to forget. Making a patient's appointment is easy. Just click on the calendar sign, enter the patient's name and mobile number. Select date and time of the appointment and that's it. A confirmation message will be sent to the patient and so will a reminder. A day before the appointment, your patient will be automatically contacted by the DigiShield agent. The Shield agent will collect the patient's symptoms, history of present illness and more. The agent will also collect any consents or indemnity that you want to collect from them. Based on the DigiShield interaction, you will be alerted to the patient corona carrier risk. It's easy to do a phone or a video consultation with the patient. DigiShield recommends that patients that have been flagged with a high or moderate corona carrier risk should be consulted via consultation first. Click on the phone icon or the video icon to do a safe and secure teleconsultation with the patient. In order to issue an e-prescription to a patient, tap on the pencil icon, tap on the camera icon to take a photo of the prescription, and you're all set. The prescription is sent securely to the patient immediately. DigiShield is easy to use and you will be online within 5 minutes of downloading the app. Download DigiShield on the Android Play Store or Apple App Store today. Protect yourself, your patients, your community. Download DigiShield for free today.
A very good afternoon to all the MASTACON delegates. Welcome everyone for the post-lunch session. To chair this session, we have two very eminent chairpersons from Solapur. First is Dr. Sudeep Sarda, who is an anesthetist, a freelancing anesthesiologist having special interest in obstetric anesthesia. He is the past president of IMS Solapur, Indian Society of Anesthesiology Solapur, and Solapur Private Hospital Owners Association. And he's particularly popular for his work in COVID. Welcome, Dr. Sarda, sir. To chair with him, we have another very popular personality, Dr. Jyoti Chitgupkar, madam, who is a consultant microbiologist and pathologist at Ashwini Hospital and Dental College, Solapur. She's the past chairperson of IMA State Women's Wing, and currently she is the State IMA Mission Pink Health Secretary. She's also the recipient of the Women Empowerment Award in 2019. Thank you so much, Dr. Jyoti and Dr. Sudeep, sir, to be chairing this session. May we now move ahead with the first talk for the afternoon session, which is by Dr. Shailendra Saureshwarkar, sir. He's an excellent, he's an MD in dermatology. He's an HIV and STI expert at the Western Sydney Sexual Health Center. He is the course program director for Sydney Medical School, and he has worked extensively on global health education and management of HIV and sexually transmitted diseases. We are honored to have such an international stalwart as a faculty for today's conference. May I welcome Dr. Shailendra Saureshwarkar, sir. He will be talking about COVID vaccine. Will it contain the virus?
Thank you very much for the kind introduction, and it's a pleasure to be here. Just wanted to confirm whether you can hear my voice.
Yes, sir.
Perfect. Well, let me share my screen so we can start the presentation. Okay. 1 minute before I hide panels. Right, so now I can't actually see myself, but it's a pleasure to be here and really honored to be speaking to the IMA Maharashtra branch, being the alumni of medical school from Mumbai State Medical College, and obviously working with Dr. Sachin Murray for many years during the medical school and beyond. I think it's the time, actually, in the way IMA organized this conference, perfect timing in terms of having some data on COVID vaccines. And I hope I'll be able to present some of that today and share some information today which will be useful for you. What I've decided to do is to present this talk in a very simple way. So looking at the SARS-CoV-2 vaccines or COVID-19 vaccines, as simply we'll call them, as to why do we need a vaccine? And then what are the vaccines that are currently available? What can we do to control COVID-19 pandemic? Who should get the vaccine? And how are we going to actually deliver this vaccine? And the critical question, when is actually the vaccine is going to be available? Let's move on. So let's look at the why question first. Why do we actually need the vaccine? Because the idea is it's a mild infection. It was supposed to be going away by this time because that's what happened with SARS-CoV-1. And that's what happened with the MERS vaccine, which were kind of cousin brothers of this SARS-CoV-2. But the reality of what we have currently is more than 59 million cases and more than 1.3 million deaths all across the globe. So if you look at Americas, Europe, Southeast Asia, Africa, Western Pacific, every part of the world has been affected and it's continuing to getting more and more infections, more so in the last few weeks again. And if you look at what's happening in India, for example, we've got more than 9.2 million cases. I'm sure speakers before me must have spoken about this. But what we currently have, and if you actually look at the data on the right side of the graph, which is a logarithmic scale, so it gives you much better picture rather than just looking at the numbers. So we have Australia at the bottom there because we've got small number of infections, so that's around 10,000 of the logarithmic scale. But if you look at the world, United States and India, they're still at the top where there's more than 9 million in case of India, more than 10 million in case of United States, and more than 1 million in case of UK. And you kind of see the perspective of the growth in a way, confirmed cases and where these curves are tracking. And what you see is that they're tracking in a very similar way. So you see growth in numbers in the US, growth in numbers in India, and growth in numbers in the UK, and possibly similar situation in Europe. If you look at the daily new confirmed cases, that's the bottom side of the graph, also the slide. You saw the peak in India a few months ago, and the expectation was that that peak will slowly but surely go down, which is the case that we see currently. But what has happened in the last few days is you see the small rise in the number of cases. And that is the big worry. I think Dr. Gangakar presented this morning about those two peaks he showed with Spanish flu, 1918 and 1919. And the concern is whether this COVID-19, which is obviously the major problem for 2020, does that become a problem for 2021? And that is what we're trying to avoid here in terms of having some kind of intervention. And on the right side of the lower slide, what you see is the same logarithmic scale showing you where kind of the countries are, the US, India, United Kingdom. And you can see a very similar story again, that the new cases are also on the rise in the UK, they're also on the rise in the US, and they're kind of stabilizing in India, but a small rise in the last few weeks. Now, that probably is sufficient in terms of giving you the reasons why we should look at this problem, that this global pandemic is not going away. The idea that it was going to be a smaller kind of outbreak in few parts of the world is obviously completely gone now. So let's look at what we can do. And Dr. Gangakar again talked about pharmacological treatment, the antivirals, the monoclonal antibodies. Neither of them actually are currently working the way they should. And actually, Dr. Gangakar also gave really good analogy of HIV medications. Now worked in HIV field for almost 25 years now. I think looking at what happened with the HIV world, 1981 when we had AIDS, 1983 when we had HIV as a virus identified, 87 when we had the first antiviral, the AZT. And by 1996, we started using 3-drug antiretrovirals. If you compare that to what's happening in COVID-19, it's amazing because within the last 12 months, we have potential for a new vaccine. HIV world is still waiting for its vaccine, which is more than 30% effective. So we don't have a vaccine for HIV yet. What we do very well at the moment is supportive care, either at home or in hospital. And that is probably the mainstay of COVID-19 care at the moment. We talk about the NPIs, non-pharmacological interventions, and we've done few of them, from individual to using a mask, maintaining social or physical distancing, to actually having lockdowns, closing borders within and between countries, closing borders within a city, to creating hotspots as I think India went, and in Australia we closed the states to each other. We can also talk about potential chemoprophylaxis. So in the HIV world, for example, pre-exposure prophylaxis for HIV is very big. And that is where I think there was a thought that potentially an antiviral drug, if it may not treat or cure the infection, it might prevent it. Now, unfortunately, we don't have that. So potentially all our hopes are now centering around vaccines, and that's why we'll talk about those today. So just before we go into details of the vaccine, most vaccines that we have today, this is a diagrammatic representation of the SARS-CoV-2 virus, very simple way. It's a very simple virus, an RNA virus. What it has is these four proteins: the spike protein, the envelope protein, the membrane, and the nucleocapsid proteins. And so generally vaccinologists would use either of those proteins to develop a potential vaccine candidates. Most of the vaccine candidates currently are focusing on the spike protein or the S protein. And that's where most of our discussion probably was going to be in terms of what the vaccines are. But then there are a number of ways one can develop a vaccine. So just to show you briefly what exactly can one look at the vaccines in terms of potentially the first one, the first kid of the block was the Pfizer vaccine, which was an mRNA vaccine. So it's very new technology using an mRNA to provide a coding to our own body to develop a protein that will then generate an immune response which will protect us from SARS-CoV-2 virus infection. Or you can go with the more traditional models such as the inactivated viruses, whole or subunit vaccines, which we have a lot of information about, or also subunit vaccines. Some of the vaccines like the AstraZeneca, Oxford vaccines probably are using the non-replicating viral vectors or inactivated virus in some other conditions. So let's look at, but then obviously, as I said, we don't have a vaccine for HIV. We have a vaccine for human papilloma virus, for example, and that took decades to come on board. So this is a typical example of what happens in a vaccine development. You go from a preclinical phase, and probably everybody's heard about this in newspapers nowadays, from phase 1 to phase 2 to phase 3, and then the approval and the marketing. All of this typically takes 10 to 15 years. That's a traditional vaccine development process. What we have is an amazing accelerated vaccine development process of 12 to 24 months. Now we're almost close to 12 months now. The expectation is that we will have a vaccine very soon. Currently, there are 48 vaccine candidates under investigation. 11 of those are in phase 3, which is no mean feat. Within 11 months of actually having the virus structure, we have 11 vaccines which are in phase 3, which is a phenomenal achievement from a global health perspective. People have looked at them, as I showed in previous slide, the mRNA vaccines, the DNA vaccines, the protein vaccines, or inactivated virus particles. Variety of different vaccines exist currently. And if you look at the pipeline of the vaccines, there are 164 in the preclinical phase, but the most focus is on those 11 that are in the phase 3, and typically those 4 that we have data for. So we're going to look at those 4 and then look at, well, what is it that may help us implement that vaccination program. So as I said, viral spike protein is where the focus is to develop those neutralizing antibodies, which will prevent the binding to the ACE2 receptors where SARS-CoV-2 virus binds. So we have those for the Pfizer vaccine, which is an mRNA-based vaccine. The chimpanzee adenovirus vaccine is the AstraZeneca or Oxford, as we commonly know that vaccine as. The Moderna's vaccine, which is similar, again, an mRNA vaccine. And the Sputnik V vaccine, the Gamaleya's vaccine, which is an adenovirus vector-based platform, which is much more traditional platform that the Gamaleya went with. And this is just to show you, we don't have much data on Gamaleya, I'll show you some though. So this is kind of side-to-side comparison. I'm sorry about the font, it's very small. First is the Pfizer vaccine, which is an RNA vaccine, 2 doses intramuscular. What we have is 95% efficacy, the primary efficacy analysis. So you've got to be very mindful of this. We have information from press releases. We actually don't have this data yet in public domain. This is all going to be available in the next few weeks. So we have to go by what the companies' press releases are telling us at this stage. The challenge with the Pfizer vaccine is that it reads storage requirements are pretty stringent. You need to store that at -60 to -80 degrees centigrade. Now, most countries in the world do not have that facility across the board. India certainly doesn't have at this stage the capacity to do the storage and then use it across the country. The projection from the company is that they are ready by next year to produce 1.3 billion doses. Now, the population of the world is more than 7 billion. So 1.3 billion doses, having just one vaccine is not going to be enough for us. So let's look at the second one, the Moderna vaccine. Very similar efficacy, 94.5%. Very similar approach, 2 doses, much better for storage. So 2 to 8 degrees for up to 30 days. Frozen -20 typically that most of us are quite aware about and is available, although needs to be scaled. To 90%, depending on which study you look, which component of that study you look at. But the good news there is that they are able to, and this is because they have a partnership with India. They're able to produce 3 billion doses in 2021. And that is where the big story is, that if we have this vaccine and it works, if we are able to deliver it, they actually have the capacity to manufacture it in that numbers that you talk about. So let's look at the first one, the Pfizer vaccine. Which showed 95% efficacy after 28 days. So you got to remember as well, the moment you get the vaccine, it's not going to be effective straight away. It's going to take at least 4 weeks. This is, in this case, 4 weeks in the Pfizer vaccine. Looking at that, it's efficacious also in people who are 65 years and above. So it's similar efficacy for those who are more than 65. Significant number of people, 43,000 participants, a very low side effect profile, which is very helpful, considering this is a new category of vaccination that we've never used before. But they have the capacity to about 1.3 billion by next year. If you look at the Moderna vaccine now, it's generally promised in the US. Most other countries haven't really bought Moderna yet or engaged into contracts. Very similar, again, 94%, very similar profile. Number of grade 3, which is severe. So this was a paper published a few months ago now, and a few weeks ago, and there was one published in August of this year. This is the Charax one, or the chimp adenovirus vaccine. It's basically a replication defective chimpanzee adenovirus vaccine, which does have SARS-CoV spike proteins. And in the phase 1/2 study, which looked at 18 to 55 years of age, it showed that it's well tolerated and does generate a robust neutralizing antibody, hoping that it will be effective. We've obviously this week, we've got the results from the phase 2/3 study, which showed that if it is given as a 2-dose regimen, there seems to be 62 to 80% efficacy. The graph on the right side actually demonstrates that you need 2 doses of the vaccine. The 1-dose component, which is the lighter color of the blue, purple, and the orange, you actually don't mount a good response with 1 dose. But if you do 2 doses, the response is very similar to younger population. This is the older population response, so more than 70 years of age. If you're more than 70, definitely you need 2 doses, and then possibly it takes time for you to mount the same immune response as a younger population. And that's a critical message in that study and that vaccine. The data that we saw this week was showing that it's 70% effective. Now, we knew for some time that 70% is kind of a cutoff figure, that we need a vaccine which is around that efficacy for us to really use it in public health practice. Although it showed a variation in a way that in one study, the efficacy was 90% in the UK, and the other study, which is in Africa, was 62%. And that's where I think the challenge was as to why that happened. There's some controversy going on at the moment. I don't want to go into that controversy as to whether the half dose was given by mistake and what that means. But fortunately, it meant a good response of 90% efficacy, over 62%. No severe cases. There's also an early indication in this that the vaccine could reduce transmission from an asymptomatic patient as well. And that's where I think really, really important, because we don't want a vaccine to just reduce the disease. We also want to control the pandemic. So that means transmission efficiency needs to be reduced as well. The best part of the vaccine, it's useful at normal fridge temperatures, and it can be distributed using our existing logistics. The Gamaleya or the Sputnik V vaccine that Dr. Reddy's has entered in contract in India with, again, very similar efficacy, 95%. We don't have much data about most of these studies, less so about Sputnik V, so we're waiting for all those numbers to come out. So what we have is potentially, and these are the headlines about, so the Indian vaccine, the Bharat Biotech's Covaxin, is starting its study or started its study this week, which is a great news. Again, there's a number of other vaccines which are potentially in the phase 3 trials very soon. Now, and this is the headline from Serum Institute saying even at lowest efficacy of 60 to 70%, Oxford COVID-19 vaccine is still a viable one. And the other one, which is the same vaccine, which is showing 90% in the UK population. Now, let's look at efficacy part of it. So what exactly is the vaccine efficacy? What are we talking about here? It's not about making the patient better, like you give antivirals, you control the virus, and then that's it, you get better, or your viral load is controlled. In this case, there are a number of parameters for a vaccine efficacy. And that's why it's probably important to spend a minute on this, just to look at what do we need to do. The efficacy needs to be protection against disease, protection against infection. So if you look at from SARS exposure, preventing infection, preventing disease, preventing intensive care admission. So you may get sick, but not very sick to go to hospital. And then preventing deaths, so reducing mortality. And ultimately, by doing all of this, you also wanted to prevent the transmission. And that's where the efficacy part of it is. When we do vaccination, what is our objective? Our objective is to generate herd immunity. Now, we all have heard about herd immunity. It's been there in newspapers for the last few months. And everybody now knows the row and the herd immunity in a way. But what we do need to do is potentially have significant number of people who are protected because of vaccination or through exposure to the pathogen, which is what herd immunity was discussed in the previously in COVID context. But then it's not desirable to expose people to the pathogen and then acquire herd immunity, because people might get sick and die. And so what we need herd immunity through is vaccination and not through people getting infected. And from what we know about COVID-19 row, it's 2.5 to 3, and we require about 60 to 67% kind of coverage of this vaccination. So about that number of people should be protected from having the vaccine. But then there are many uncertainties about what is the nature of immunogenicity, how much this pathogen causes a response from the body that protects itself. Whether the humoral is important or cell-mediated is important in terms of neutralizing immunity, and how long such protection lasts. All these questions are still to be answered. Although we do have potential vaccine, we don't know the natural infection or the vaccine, how long can it protect us. So there are a few questions in terms of herd immunity, efficacy of the vaccine, how efficacious is the vaccine, and that's going to determine what happens and what population of people will get the vaccine, and then the transmission chain can be stopped. We don't know the duration of this vaccine. There's potential for a waning vaccine immunity. So the efficacy might go down with time, for example. And that means that you might be prone for getting infection. And we also need to really target this to the particular population. We'll look at that in more details. It's the who question. How do we target this vaccine? Who should get this vaccine? The Australian Technical Advisory Group came up with a very simple and I think very useful guide in a way, and this has been across the world, similar kind of guidelines. Older people, because they are at risk of getting severe disease and dying, or people with pre-existing condition. And Shashank did a fantastic talk on diabetes and its kind of relationship with COVID-19 this morning. But then those second group is people who are at increased risk of getting COVID-19, the healthcare workers. And we've seen significant number of healthcare workers getting affected across the countries. Residential or aged care workers, that's been the problem for many Western nations. Disability workers, people who with disability are at increased risk again and need to be protected in that sense. And people obviously in detention facilities who are close together, who live close together. And then the last group is people who work in critical services, defense forces, emergency service providers, public health staff, food, water, electricity, all those critical infrastructure, they're also really important. What we have is this health worker. Who is a health worker? And what is the risk of this health worker? It could be a doctor or nurse, public health professional, lab people, personal care, community health workers. Healers and practitioners of traditional medicine, they're also health workers. Management workers, cleaners, drivers, hospital administrators. So there's really a broad health worker classification. What we do need to do is, and WHO has actually done a very nice job at this, looking at who is at low risk population, who is at very high risk. So if you're working in intensive care where there's potential for aerosol transmission, you're at the highest spectrum. You're working with COVID, you're in a closed environment, and there's potential for aerosol transmission. You're working with COVID generally in a little bit normal hospital environment, you're probably at higher risk of it. Medium risk is you potentially may come in contact, but you're not working with COVID or suspected COVID patients. So there's different matrices that we might need to use to look at it. And there's an attempt by WHO in this SAGE roadmap to give a perspective. There are really different pieces of the puzzle here. One is who is at risk of getting infection, who is at risk of mortality and morbidity because of COVID. But then the question is, if you have 10% of the vaccines, so for example, India has 1.4 billion people. If we get 10% vaccines, what are we going to do? Who are going to prioritize? And that depends on whether it's your area is in community transmission, whether your area is sporadic cases or clusters, or you have no cases like in Australia, for example, or New Zealand. You haven't had cases. So the priority changes according to that, from health workers to essential travelers in no cases, because they are the ones who are going to bring the infection. So they need the vaccine because you don't want to introduce the conditions rather than prioritizing those who are in the country. Look at, if you have a bit better availability of vaccine, you can expand to more older adults or people with comorbidities, for example. And then you go to, in no case scenario, you give it to all the travelers who are coming in or make it a condition there. If you have a lot of vaccine availability, which is unlikely the case in the next year at least, then you could expand it to really everyone practically. Pregnant women, obviously, depending upon the safety of it. And so there are really different ways to look at this question. Let's look at the how question. How do we actually do this in a way? So there are a few roadmaps available. So I've just put the WHO's roadmap of prioritizing use of COVID-19 vaccine. And WHO has come up with a values framework. I think it's essential. And we've worked in HIV for a number of years saying those most at risk or marginalized population will not get priority unless we create a value-based framework for COVID-19 vaccine distribution. And that is true for every practitioner. Even in your small practice, you got to really prioritize. If you get 100 doses for your clinic, who are you going to give it to? And that's really interesting. COVAX, which is the global collaboration to invest COVID-19 vaccines, it's led by Gavi, CEPI, and WHO. And the reality is that no country is expected to procure sufficient doses to vaccinate the entire population, and that's really important. If you do get the vaccine, the challenge is vaccine procurement, supply chain, cold chain management, because there are a variety of different requirements for cold chain. If you go with multi-vaccine approach, a big challenge for cold chain, because with the same distribution network, you will need -70, -20, and a normal fridge. And that's where the challenge is. How do we actually do this delivery? Planes, trains, truckers, remote areas, how are we going to deliver vaccine there? So a lot of questions to think about. What we don't talk about a lot is training of frontline workers and social mobilization. We're not communicating with people in terms of what these vaccines are. What are their questions? What are the anxieties of the population about this vaccine? Are they willing to take the vaccine? And I'll show you some data around that. And the training of healthcare workers is critical in this matter. There's another concept that I want you to understand, the vaccine hesitancy component. Basically, what it means is that people are reluctant or they refuse to vaccinate for a variety of different reasons. The most common ones are complacency. They don't think they're at risk of getting this, or I've got it already, so I'm not going to get it again kind of thing. We don't know that yet. Inconvenience, I need to travel sometime to get it, take time off work or lose my wages for a day. Or confidence, we don't know this mRNA vaccine. What does it do? There's a problem with toxicity maybe. All those things. I think the health workers are the critical component of what's going to happen. We look at this, and this is the data, really interesting survey, setting at 50%. And this is really looking at the vaccine hesitancy. This is much before COVID time. There's a recognition about vaccine hesitancy, that people are reluctant to take the vaccine, especially the adults. And so we need, on one side, we need public health people to look at explaining how it works, how it's developed, what's the efficacy, when do you need to take it, how many doses, and that the fact that population level coverage is important rather than individual level coverage. But then there are issues, norms of society, religious and moral issues, risk perception. People may not perceive they're at risk in terms of then past experiences. Oh, I went to take the influenza, it didn't work, so I'm not going to take COVID vaccine as well. So we're going to deal with all of this as healthcare providers. We've got to have our answers ready, like almost an FAQ with us all the time to answer those questions, because what we say is going to matter. What health professional recommendation do is they actually create that trust with healthcare provider and the ability then transforms into getting a vaccine. Availability, it's interesting that there's significant social commitment. Again, probably a flow-on effect from the HIV era about providing medication at the cost in HIV, the sense of urgency, the sense of equity and access. The critical bit is about integrating digital solutions, like what Nandan Nilekani was saying about using the Aadhaar and unique ID platform to distribution, to track the vaccine, first dose, second dose, who's got the first dose, who's going to get a second dose, and that's really important. And then using the human resource for training. This is from the US Department of Health Services looking at, you have to prioritize the population first, allocate the vaccine, distribute it, administer the vaccine, then look at the uptake on the second dose, and then look at where we can have the recovery in terms of that. At the same time, track the supply, look at the uptake, monitor the adverse events, because these are all new vaccines for all of us. This is really interesting paper to look at adult vaccination. I think the biggest challenge India has that it doesn't have an adult vaccination program as such. The only adult vaccine that we have is tetanus. That's the only adult vaccine that we use in pregnancy, practically. And so the challenge we are going to have is, how do we run an adult vaccination program without affecting the child vaccination program? That's been very successful. We do somewhere between 80 and 90% now, and really good in the last few years. We don't have surveillance. We don't have national guidelines for adults. We don't have a recording system for adults. The providers don't know what exactly to recommend in a way. It's a lack of knowledge generally. So education of healthcare providers is critical. All of you who are in the IMA, for example, really important that each of you are the ambassadors now to then advocate, understand, and promote the COVID-19 vaccination program when they become available. So that's really another important part. The reality is that we are already short of human resources. So we're going to need a lot more human resources to be trained in a very, very short amount of time. We've given 1 billion vaccines over 10 years. This is giving 1 billion vaccines in 1 year. Very different scale compared to childhood vaccinations. Children are born one by one in a way, slowly. If we are talking about immediate, urgent scale up of vaccination. And then the last question about when. Well, we don't know, obviously. We know that the phase 3 efficacy has been presented as a press release. We haven't seen the actual published data yet in a peer-reviewed journal. So we don't know exactly. What we do know, though, so for example, which you can't probably see it very clearly there, India has procured 1.6 billion doses of vaccine. That doesn't mean we have 1.6 billion doses. But 1 billion of them are Novavax, which is not in the picture yet, hopefully next year. On the right side is the time required to manufacture enough vaccines. If you focus on one vaccine, if you focus on RNA vaccine, it's going to take 80 to 90 months to vaccinate the world, which is 6 to 7 years from now. If you look at the replicating viral vector vaccines or protein subunit vaccines, it's still going to take more than 3 years to actually vaccinate the world. So even if you have the vaccine in 3 months, it's not going to be that the world will get the vaccine in the next 3 months. It's actually earliest it can happen is 3 years, possibly beyond that. And this is to show you where India stands in a way about vaccination coverage by population and COVID-19 burden. India is sitting at about 80%. This is how much vaccine we have for the population, which is booked. That doesn't mean we have the vaccine. It just means that India has blocked those doses. Australia is sitting at around 250%. Canada probably has the highest, about 500%. So they've taken 5 times the required doses. They've booked 5 times the required doses. India is reasonable at the moment, but obviously huge population. If you need 2 doses, hopefully we will only need them once. If this vaccine is like influenza vaccine, which you have to give every year, I think we are in a big expense shock in a way. And over time, that's going to be a challenge for us. So in summary, I mean, it's been a 2020 speed rather than a test match speed for the vaccine development. So we've done very well. we've actually done phenomenally well to stick to this 2020 timelines. We canceled the 2020 World Cup, which was going to be in October here, but I think at least we hopefully will have a vaccine very soon. The results are encouraging. Without going into details, because we don't have them yet, there's potential for a successful vaccine, much better than HIV. So for example, after 25 years of HIV vaccines, the best we have is 31%. But we need more data on age. We need more data on severity of how much the vaccine will reduce severity, long-term data. There are challenges in supply chain, delivery of vaccination, and don't forget community education. And that's where the IMA probably is critical. That's where all of you who are on this call are very critical to really create that kind of brand ambassadorship through the IMA and through individual healthcare providers. It's best topic. I mean, sometimes you think, well, what am I going to do as a single doctor, a single nurse, or a healthcare professional sitting in small area of Maharashtra, for example? And I think this is where you look at saying, if you think you're too small to make a difference, you haven't spent, which all of us in India have spent a night with mosquito. We know how important malaria is and other infections that mosquitoes can spread. Thank you very much.
Hello. At the outset, I'm very much thankful to Dr. Shailendra. Really, I am proud to have you in this session. Actually, you have highlighted so nicely on this most awaited topic, that is vaccine, which is being eagerly awaited by every Indian, not only Indian, I think whole world is waiting for it. To get rid of imprisonment in pandemic and to get freedom. And now population has very high expectation from these vaccine candidates now. And really very thankful for highlighting all the topics, what, how, when, who, everything. It was so nicely put forth of us. Really thankful to you. I would like to ask some questions
Sure.
to you. Yeah. Dr. Sudeep, please.
Yeah, there is one question from Dr. Rahul. He asks whether we can recommend vaccine for individuals who was already infected with COVID-19 and with lowering of or no antibodies.
Look, it's a good question. The problem we have is we don't have the answer yet. So because when you say antibodies, what kind of antibodies we are talking about? Because the antibody tests that we do are not neutralizing antibody that we look at most of the time. So that's a tricky bit. Even in those who are infected, there is no correlation between some people who get antibodies late. We think, okay, maybe there is obviously a challenge there. But those who get severe disease also sometimes get neutralizing antibodies very earlier on. So the correlation isn't very clear yet. And so what should we do with those who are already infected? Should we give them a vaccine or not? I think we got to look at the data. I think the reality is that we probably wouldn't know for some time. In that situation, the question is, the vaccine is safe. I think, I don't think we'll have data on those who are infected and what the vaccine has done to them, because that will take at least a few years from now to get, because that's not going to happen. Whether to deprioritize those who are already infected, and that's the critical question. Should we then say those who are infected are last in the queue and recovered from COVID? And that's where I think trick bit is. I mean, if you imagine this 100 old people in your township, right? 10 of them have got COVID and recovered from COVID. Should you give the vaccine to them because they were prone to getting COVID, as opposed to those 90 who did not get COVID, even though COVID was around? And that's, these are very, very difficult questions. Some of them are actually ethical questions rather than clinical questions. But at this stage, I think there is no data to suggest that you don't need a vaccine or that vaccine is going to be problematic, because I don't know the answers to that question. I think as more and more data will come on neutralizing antibody, the duration of it, because even that is not clear. How long does it last? I'll give an example. My mom and dad both had COVID. They live in Aurangabad. Both of them recovered from COVID. Thank God for that. My father had antibodies within few weeks. Mom did not get severe disease, and she took 4 months to develop antibodies. What does that mean? And I said to mom and dad, don't worry about the antibodies. I mean, if your health you improved, we don't know what that test actually means at this stage. It's a very difficult time, and I get that. But I think we just have to wait for more data on the antibody, which is the right antibody to look at when we decide make those decisions. And again, it's the same thing, whether the test is going to be more expensive than the vaccine, because vaccine looks like we're going to have in 500 to 600 rupees. The tests are costing a lot of money.
Yeah, yeah. Actually, you have elaborated very nicely. Amongst that, I like one topic, that is there is hesitancy for the vaccination. We really see such hesitancy amongst medicos also. What is the advice that you will give for medicos? Because government is pushing in India for vaccination for medicos first, and there is a lot of hesitancy because we don't know what is the safety, what are the long-term complications of that. So what is your advice as an expert?
Look, I think we've seen that time and again in a way. So for example, in Australia, whether to take influenza vaccine or not, it's universally recommended if you're working in hospital setup. And we take it every year. Not everyone does, obviously. If your risk is higher, which it is if you're a healthcare provider, just because the vaccine is accelerated doesn't mean you're not doing protocols. What has happened is everybody is turned to develop the vaccine. Every effort that would have otherwise spread across 10 years has been concentrated in 1 year. So whatever process we are going through is not a problem. I think if there was a vaccine which was going to have less side effects, which it looks like the case in all 3 studies that we know so far, I would recommend healthcare providers to go for the vaccine, because as much as we are at risk, but we also should be leading this. So it's not going to send the right message if you are the ones who is not taking the vaccine and then you are recommending the vaccine. I think it's counterproductive in that sense. If the safety data and if it's approved for use by really stringent regulatory bodies across the world, and now everyone gets those WhatsApp messages about what this may mean and how they're doing genetic engineering to put this. Please, we are all educated professionals. We should dispel those myths. We should trust in the medications that we get through all the rigorous process. And it is critically important that healthcare providers become the first ambassador to take it rather than the last one to take it.
Right.
Thank you very much, sir. Really, we are proud to have you from Sydney here. आपने 4 चांद लगा दिए वैक्सीन के साथ हमारे प्रोग्राम को.
Thank you very much.
Sir, we all till today we are not with vaccine for HIV. Even H1N1 we got it very late, and still we are very much expecting COVID-19 vaccine. Hope for the best. I think we should hope for the best and pray God that we could develop herd immunity along with this vaccine. And thank you very much, sir. If you could highlight on some adverse effects of these expected, are there any expected adverse effects?
So look, as it is with every vaccine which uses obviously some kind of virus particle or a mimicking particle, you expect some reaction which is like virus, for example. So what is more common in all the studies is some people getting fever, some people getting fatigue. Fatigue seems to be the one. And if you've got, and which you probably have more experience in India in seeing more patients with COVID, we don't actually have much in Australia in terms of COVID patients. So fatigue is probably the one. You can potentially see the patient and then look at the fatigue. I think that's probably a critical one. Injection site reactions, so they are common, about 2 to 3%. So that's the expected one in a way. Nothing major has so far happened. Now, obviously, it's very short-term data. You're looking at the best 3-4 months data. So we're going to wait and see. But I think the way it looks pretty safe.
Okay.
Thank you very much, sir. As this is e-conference, we would like to present you e-momento. And once again, thank you very much. Presenting e-momento to Dr. Shailendra Savleshwar from Sydney and participating in this very nice conference. Thank you very much, sir.
Thank you. It's a pleasure and best of luck for the conference.
Thank you, sir.
After this extremely comprehensive talk, moving on to our next topic, I would like to humbly remind all the logged in delegates that tomorrow morning we plan to start half an hour early for the virtual inauguration ceremony of MASTACON 2020. So I request everyone to kindly log in half an hour early. We plan to start by 8:30. May I request the chairpersons to kindly introduce the next topic, please?
Yeah. Uh, Next topic is, it is National Digital Health Mission. It is by Dr. Praveen Gedam, who is IS. Actually, in this topic, uh, it is for the digitalization that is proposed in India on large scale. So Dr. Praveen Gedam is going to highlight on that.
Thank you. I am immensely pleased to introduce Dr. Praveen Gedam, who is an IAS. He is the Additional Chief Executive Officer of the National Health Authority of the Government of India. He has done his MBBS from GMC Nagpur, and he is an IAS of the 2002 batch of the Maharashtra cadre. May I present to you Dr. Praveen Gedam.
So, thank you very much to IMA Maharashtra and IMA Solapur for giving me this opportunity to be back amongst doctors back in Maharashtra and also getting connected with Solapur once again. Thanks to everybody. Right now, I am Additional Chief Executive Officer of the National Health Authority and in charge of implementation of two health-related programs. One is Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, and the other one is National Digital Health Mission, which some of you would have noticed that during the independent speech of Honorable Prime Minister, he announced Health ID and some other advantages of the Health ID. So I am actually driving that particular initiative, and I understand it is a very complex kind of system that we are planning to roll it out in India, and may not be easily understood. So I will be happy to take questions if you have any. I have a small presentation to make, which I will do, and then we'll take questions from. So I hope this is visible.
Yes.
Yeah.
Yes, sir.
So the problem and the necessity of digital health is too well known to be discussed in detail. But in short, if we discuss about citizens or individuals or patients, they themselves don't have their all medical records at one place, and I am sure this problem is there, which each one of you must be facing. There is a lot of issue about qualification of doctors, and particularly I remember my period in Usmanabad when we just took a survey and we found we could arrest 54 fake doctors in one day. So that's the scale on which fake doctors are operating. Then information about doctors' healthcare facilities is also not easily available to citizens. About medicines also, the information is limited. As a doctors, hospitals, laboratories, same problem. You don't have complete access to their longitudinal medical history, and that creates an issue in giving providing follow-up healthcare, and also some difficulties in remote consultation, though of late it has increased. And ease of doing business, when it comes to various types of permissions, we tried listing it out. A full-fledged hospital may require up to 60 different types of permissions, and that's definitely going against the ease of doing business. For policy managers like officers sitting in my position, we don't have complete information which will allow us to take suitable decisions, and monitoring becomes difficult. So these are the issues which we are trying to address through Digital Health Mission. Before I coming to the components of NDHM, Very important thing, this is purely a voluntary initiative, and this has been officially declared by the government that we will not make it mandatory. If you are willing as a doctor, hospital, or as a patient to be a part of this initiative, you can come in. Otherwise, you can opt out of it. You rather you don't even join. And even if you don't join, there is no reduction in the level of facilities or benefits that government is supposed to provide to you. So this is a purely voluntary initiative. The second element, a very important one, we are very particular about privacy and security of the data. This is a very sensitive data, and therefore the element of security and sense of privacy is of very high nature, and this is a part of design structure of the IT solution that we are building in. Then we also appreciate the fact that a lot of areas, particularly rural, hilly, tribal areas, they don't have good internet connectivity. There is big digital divide in the society, and therefore things like offline modules, etc., are also under development. Ultimately, we are looking forward for a seamless portability which will connect all the healthcare institutions. I will explain how it is going to happen, and we are not limiting our task only for the purpose of providing medical treatment, but we are going beyond the realm of that into preventive and wellness centric approach. So this is an important slide. How we are going to, what we are trying to achieve is basically interconnecting the electronic systems in various hospitals with various doctors with each other. And how is that going to happen? That may be the question that you may be thinking. So if a patient goes to a hospital, say in Solapur, and he is referred to some hospital in Mumbai, he goes to Mumbai, then a doctor in Mumbai should be able to see his health records in the computer system of Solapur hospital with the consent of the patient. That's the idea. And this is one of the major benefits that this mission is going to bring. And how it is going to happen, each person who intends to join this system will get a health ID. We have already started the pilot in 6 union territories. Maharashtra will join soon. So the health ID is unique for a person, and all the health records created with the doctor or a hospital who is a part of NDHM will have a facility to get linked to the health ID. So whenever a hospital in Mumbai where he has gone searches for his health ID related records, his records across India in all hospitals will be displayed to the doctor who wants to see it, and patient will have to give consent that yes, you can see my records in Solapur, Pune, Nagpur, Aurangabad, these hospitals. He may withdraw, he may not give consent to some of the records, and that's how doctor will be able to see these records. So this health ID is basically a registry of unique IDs which will be given to each person who may want to register. This is one. Second, similarly, we will be having a registry of doctors, because again, it is necessary that only genuine doctors are made a part of ecosystem. So we have to have some element of check. And we have already discussed with all the medical councils of all the pathies, and those who are participating, those doctors who are willing to join, they have to fill a simple form, and their name will be officially onboarded by the concerned medical council after verifying that they are actually doctors. So a doctor will also get a special ID. And similarly, for health facility, that is hospital, clinic, laboratory, pharmacy, similarly ID will be given. So these three are the core registries which provides unique identity required in the digital health ecosystem. Then there are certain, and these will be manned only by government. We will be managing all these three building blocks. Now coming to reference applications, these reference applications will be provided by government, and we will also allow private players to provide their reference application, which will get integrated with our three registries. So I'll give you an example. So you are all aware of something known as UPI. UPI it is an IT system for financial transactions. So UPI can be compared with NDHM. Then there is a government app which is known as BHIM, Bharat Interface for Money. And so this is the reference application. And then there are private apps like Paytm, Google Pay, Phone Pay, and all that, which are other applications. But the core platform which has allowed all this system to evolve is UPI, which is NDHM. And we will be providing certain reference applications which are developed by us and will be rolled out soon. And will also allow other players to come out with the products which doctor, and then you are at liberty to choose whichever you want to choose. So the first such product is personal health record. So I have an app called PHR or personal health record. So I enter my health ID there. So it will fetch my health records across all the hospitals in India at one place, and it will be arranged there. So I will be having my records in my mobile, and I can also use this same mobile for providing consent whenever some doctor wants to see those records. So this is PHR. Sorry, was it disconnected?
Yes, sir. But we can see you right now, so you can.
You can see, and my presentation is there.
No.
Okay. The EMR is
Now it is
electronic medical record. I hope it is clear now.
Yes.
Yeah. So in particular hospital, they use different types of systems. So I am aware of government hospitals where there is a system called e-hospital. So it is basically medical record which is in one IT system. So AIMS or let us say Grant Medical College, they may be having one particular medical record system where medical records of all patients coming to that hospital are stored and again linked to specific IDs. So it is a hospital specific software. And similarly, additional modules for additional services like telemedicine, e-pharmacy, they are also contemplated. Telemedicine will also be rolled out pretty soon. So to explain in short, at the center we have three registries: Health ID, DigiDoctor, Facility Registry. Then there is an electronic system called Consent Manager and Gateway. So this is Consent Manager is electronic system where health information user, HIU is a health information user, and HIP is a health information provider. So who provides information? It will be a doctor, hospital, laboratory. And who is using it? Another doctor, another hospital, another laboratory, or patient himself or any other. So whatever request is made by them for any health record, it will go through Consent Manager. It will verify that the person who is with whom the record pertains to, he gives his consent, and only then it will be shared. So this is a very important element which we have incorporated to take care of privacy and security. In the first phase, we have rolled out this system in 6 union territories of Andaman, Chandigarh, Dadra, Lakshadweep, Ladakh, and Pondicherry. And in the future, we are likely to expand it in other states and various union territories. These are the figures which show the, it has been launched on 15th of August, not long ago. So more than 3 lakh health IDs are generated. More than almost 800 facilities are already onboarded, and more than 1,000 doctors are also verified by the concerned medical councils. Maharashtra will, maybe we can consider coming in a couple of months. So these are the advantages which we look forward to. Telemedicine, EMR, PHR, I also discussed with you. Then, sorry. Health and wellness based value added services, AI and ML based clinical decision making. Now, I am sure you must be having a lot of questions, but you can imagine the quantum of health data that will be generated in the country as large as India. And once we are in, we bring it that level of standardization of this health data, this will be gold mine for research and evaluation. I can also understand the concerns that there will be attempts, there may be a concern that okay, somebody may want to use it commercial purpose. We have explicitly kept it out of the scope, but we definitely intend to use this data in anonymized and aggregated fashion. So while taking care of the privacy of individual by masking the identity of the person, we will be in a position to monitor and evaluate the various patterns, epidemiological patterns in the scenario of public health. We can also do various kinds of medical research, and a special policy will be laid out for that, so that privacy is maintained. Number one, commercial exploitation of data is not done, but at the same time, larger public interest is also not hampered. And obviously, the efficient of use of resources, I mean to say, we will be able to make best decisions. Which district requires how much of investment, how many doctors. So all these management decisions, policy level decisions should be possible. Claims processing, many of you may be interacting with health insurance companies. You know, a lot of them are manual. You submit it on email, they physically check it, or even CGHS and all that. So this we intend to have it in electronic format, and we are also developing health claims platform. So this is in absolutely brief that I have tried to explain. I understand you may be having so many questions. So what I will do, I will stop here and will rather take as many questions in the remaining time as possible. Please feel free to ask whatever you want to ask. I will be happy to answer.
आहात सोलापूरचेच आहात, तुमच्याकडून ऐकायला खरंच खूप छान वाटत होतं. This was very much fascinating and applicable app. I think this National Digital Health Mission is really will be helpful in future in this electronic area, we all think. But a few questions, they have already come, and first up at the outset, I will ask you a question about when we are collecting this much tremendous data with us about health, are there any chances of data stealing?
Okay, so data stealing will take place wherever the data is stored from. We do not intend to have any centralized repository of data. The only centralized repository of 3 registries, Health ID, Doctor Registry, and Health Facility Registry. The data remains where it is right now. So if you have a hospital X who is using system developed by IT company A, so whatever is your server, wherever is your server, it remains there. So this is known as a federated architecture in IT language. So there is no centralized data. This is very important and has been deliberately done to instill the confidence in doctors and patients, number one, and also to do least possible disruption while moving towards the system. What we are planning is only a platform which connects these various hospitals, that's all. So the data remains with you, one. Two, whenever any hospital wants to integrate with our system, so in case of UPI, various banks like SBI, Maharashtra Bank, or Punjab National Bank, they have integrated. Before integrating, we check whether their systems conform to basic security standards or not. We will not be allowing anybody just coming and plugging in their systems. We have a process which we call sandbox. The details on are on our website. So hospital, let us say there is a private company called X, which has a chain of 10 hospitals across Maharashtra, and they must be using some software. So that software solution will be first tested into our system to see that it is compliant with security and privacy protocols, and then only it will be onboarded. So that is another thing. Then these are the technical solutions, and I can assure you India has enough technical capability. We have the highest quantum of sensitive personal data in the form of biometric of 1.4 billion people in Aadhaar, and there is not a single documented case of leak of such data by Aadhaar. So we are practically, you can say, using the similar or team with the same expertise for providing architecture here. Plus, also there are so many legal provisions. If somebody tries to do it, there are enough provisions in law to punish such person so that there is some deterrence.
Yeah. So I do have one question. That is, we do have a lot of data. We just came to know that it is already implemented in a few of the places of India. The one more thing that I would like to ask is, this data is possible in bigger setup. Is there any plan to have in smaller nursing homes in future?
See, when I discussed about the principle of inclusivity. Bigger nursing homes probably or bigger multi-speciality hospital cater to top 10% or top 20% of India. Yeah. And most of the particularly rural India, they are dependent on single doctor clinic, who may himself, he and his compounder managing everything. So the reference app which we came out with, we intend to make it available at a very low cost, or if possible then probably free of cost to everybody who wants to join this ecosystem, because everybody may not be in a position to spend a few lakh rupees or a few crore rupees to get such IT system developed. That is number one. Number two, when we in a way provide the level playing field and a transparent playing field to private companies, they are known for innovation to come out with better products, cheaper products. So at present, we are having more than 400, almost 490 applications for our sandbox, in which various private companies are testing their products. So once they are given go ahead, they will go into the market and launch their product at whatever cost they want to. And I'm sure, given the kind of competition that we have, you will have better and better types of products available at cheaper and cheaper cost in the future. So I think cost should not be a issue here. And when it comes to hardware, I think you need not have additional hardware over and above what we are using. It's like providing internet connection to a PC or a laptop where you were not having that earlier. So I don't think the cost is an issue here, and this cheaper solutions are on its way.
Okay. There is one question to Dr. Savleshwar. Previous speaker, Dr. Savleshwar, sir. Sir, are you online?
I can't see, however.
Yes, I'm online.
Yeah. One question. What are the criteria of selecting a vaccine for yourself, and what is your best choice? This question is asked by one pathologist.
Sorry, can you repeat the question? What is the criteria for
selection of a vaccine for yourself, and what is your best choice? Very
like, yeah, I did respond to that comment because it was on the Q&A to that person. I think it's a good question, obviously. As I said, again, we don't have enough information to recommend either of those three vaccines that are currently being discussed. What we do know that they are safe. What we do know that there's going to be differences in how they will be available to a population because of the temperature requirement. So the recommendation, if you're a rural doctor in a remote part of Maharashtra, will be different to somebody in Mumbai. And I think at some stage, the government will make those choices, saying, we got these 100 vaccines, 30 of them require -80, 30 of them require -20, and 40 require 5 to 8. And what will happen is they'll recommend that. So you may or may not have that much choice. If they are all side effect wise similar, efficacy wise reasonable, I think it's about matrix again, same thing, availability versus the speed. What should I take? I'll take the one that's first available. Last thing you want to do is wait, because what is very well known now in terms of modeling studies for yourself as well as for the population, because you're not alone in this COVID-19, you're with your community. Because getting a vaccine 70% effective doesn't protect you 100% because you'll still be vulnerable. That's why everybody should get it. And that's why I'll probably go with whatever is first available, because the earlier we take, all of us, the vaccine, the less likely, because we are, as much as we are at risk, we are also the vehicle for transmission, because being in the field we are in. So it's critical that you actually go in early. So I think the speed of vaccination and speed of people's uptake is more critical than whether it's 70 or 80% effective. Keeping in mind, safety obviously is important for all of them. Once the safety parameters are done, 70, 85, 90 probably wouldn't matter that much. Speed of vaccination is probably what is going to be more important. So I would take the first one available.
Yeah. For Gedam sir, what is the likelihood of chance that this mission will be implemented in Maharashtra? Because at present we are speaking of Maharashtra. So what is the
Its chance is 100%. It's a matter of time when it will be implemented, because the mission is for nation. The National Digital Health Blueprint is also available on our website. And I'm happy to tell you that we have already received a letter from Government of Maharashtra, the Honorable Health Minister of Maharashtra writing to Honorable Health Minister of India, requesting him to get it implemented in Maharashtra as early as possible. Right now, we are focusing on smaller areas to understand the problems which are being faced, so that we correct these problems, improve the systems before we go to the larger states like Maharashtra. So it is in pilot phase, and in Chandigarh and Pondicherry, which are pretty big cities, plus 4 other UTs, we are testing it right now. Expect another maybe 2 or 3, 4 months max.
Okay.
Sir, when we are developing our health sector so digitally as well as very fast now, will we increase GDP on health sector?
I see. I increased expenditure on health sector. It's something which I should not speak about because I am not the decision maker. But one thing is sure, that health is at the discussion much more than let us say highways, roads, or irrigation, because of the present situation that we are having. Digital health mission will certainly help in one part: arbitrary utilization of funds, because a particular person is from a particular village or particular district. Therefore, let us take that medical college to that place. Probably if more data and evidence is available in the form of information, then these decisions will be evidence based, data based, and it will be definitely helping the suitable appropriate use of resources. So we will be able to identify gaps correctly, so that what is required, whether I should go for MRI or CT in a particular level of district hospital, or these decisions can be taken better. So the same rupee, I'm sure it will increase, the expenditure will increase, but the efficiency of utilization will also increase.
Sir, when still today, many of our people don't have Aadhaar card. So do you really think with HID we will reach to each and everyone?
See, Aadhaar penetration in India is almost 95%, which is, I think, very high. One. Two, for health ID, we have not made Aadhaar as mandatory. Aadhaar is one of the way of getting health ID. You can use your mobile number also. And in the near future, we are going to allow all alternative documents which you see typically on the day of elections, like driving license, passport, PAN card, as one of the way of identifying yourself to get the health ID. So we want to democratize the health ID as much as possible. It should be possible. It takes less than a minute to create a health ID on internet. You can create it on your mobile, and we have also extended this facility of creating the health ID to doctors and hospitals, where a person not having mobile goes, he can also get the health ID. So during his first encounter with the hospital or a healthcare facility, he can get his health ID and get started. So I think in the coming days, this number should exponentially increase. We are estimating approx 20-25 crore in 2 to 3 years.
Yes, sir. Thank you.
Okay. For that, there are so many policies that are being changed from government for health aspect. So whether we need to change our software, any other changing of our software, whatever that is existing in that.
Mostly the answer will be no. Generally, software companies take care to keep their products updated. It is a very dynamic kind of field. And I don't see the only thing that will be required is whoever is providing software to you, he will have to take couple of steps to get integrated with the NDH ecosystem. Now, there are certain issues I will explain, certain issues in software. Some softwares are compliant with standardized nomenclatures in medical system. There are 2-3 types. One is SNOMED City. Many of you may be aware. The SNOMED City is, then there is International Classification of Diseases by WHO. So there are so many classifications. And in medical system, what happens? A same disease or same procedure can be described in more than one way. And both the ways are correct. You write cardiac arrest, you write heart attack, you write myocardial infarction or a particular coronary artery blockade. All are same thing. And the patterns vary across India. So a software may or may not be compliant with these different types of terminologies. So we have kept the system flexible, which will allow the language which computer likes, the standardized language, the ICD or SNOMED. This is one end of the spectrum. And we have also allowed you to write it on a piece of paper, click the photo and upload the PDF file or JPG file, which will not be readable by the machine. But since we understand that we have different kinds of softwares which are being used in different parts of India, this particular facility has been incorporated, which allows you to absolutely non-standardized way of writing it, like CTOL, to absolutely standardized way of writing this thing, and all the possibilities in between. So that bringing different types of solutions, doctors with different levels of IT skills together becomes easier.
There was one more question from Dr. More. Why Aadhaar card is not accepted in vaccination list of doctors and staff? Actually, yes, sir, please.
I'm not, I mean, what exactly is the question?
Sir, when database for vaccination was collected from all doctors by government, they have not accepted Aadhaar ID in this database.
Yeah.
They have asked us to add either our license or PAN card like this, but they have not accepted election, voter card, etc.
Okay.
But not Aadhaar ID.
Okay, actually, I'm not dealing with the COVID vaccination management part, but what I can understand, maybe the reason is that Aadhaar cannot be made mandatory for anything for which, unless government is providing subsidy. So Aadhaar can be made mandatory for subsidized food grains from a ration shop, but not for others. So maybe that may be the reason they might have told it is voluntary, and something down the line it gets the communication error. But I think Aadhaar is definitely going to be one of the voluntary options from what I hear from other meetings for establishing the identity. It's going to be voluntary, not mandatory.
There is one question to Dr. Shalendra. If anybody is having antibodies, but he had never diagnosed as positive patient, COVID positive, whether he will need vaccination?
Question again, I think a lot of people don't develop symptoms or a disease because of COVID, and they may have been exposed. We looked at the serology data from Mumbai or Pune with very high percentages. Not everyone had the COVID-19 disease, but they were infected with SARS-CoV-2. Now, we've seen some reinfections, but very occasional. And so the likelihood of them getting it very soon is probably limited. And that actually boils down to the question of how long is the duration of efficacy of natural immunity versus vaccine given immunity. We don't know the answer to both questions yet. As the time goes, I think we're obviously very curious, but at this stage, we need to wait a few months before that becomes clear, saying, is there going to be a second wave of reinfections? Now, we haven't seen that yet. Reinfections are happening occasionally. And if that is the case, then potentially there's a opportunity here to, and especially, obviously in India, we do have opportunity to really follow these people up and see what is happening. Now, whether the vaccination given to those who are already infected mounts a better response, much more stronger response, and that's also a possibility there. They may not need the vaccine on one side to having much more stronger response to the other side. So that's where I think we're playing in a very broad base at the moment. We don't know answers to significant number of questions. This disease has only been around for 12 months or less. And so that is where the issue is. Again, should you go front of the queue or the bottom of the queue? And that is going to be, again, another challenge. I think at this stage, if you were asymptomatic to begin with, if you're not at risk, if you don't belong to any of those criteria, healthcare workers, older adults with comorbidities, and essential workers, you may be bottom of the list. The question may not arise for a year or two, because you actually may not be eligible to get the vaccine in the first year at all, because of a variety of different priorities before you are given. And then again, if your protection is lasting 12 months, well, by the time your queue number comes, 12 months will be over, so you'll be eligible to get it. I haven't seen any data saying that they're going to make antibody test mandatory to get the vaccine. That hasn't come up yet for discussion. But I'm sure it will be discussed when we know whether the antibodies actually means anything from protection. At the moment, it doesn't.
Okay. One more question is asked. That is, what is this the first vaccine that is being developed with mRNA, or previously any other vaccine was developed? Because it is said that this vaccine is developed in very short span. So
look, I actually didn't show the slide. Maybe I should have shown the slide. The advantage of mRNA technology is the speed. And because we needed a vaccine very, very quickly, mRNA was taken up as a technology. mRNA as a technology has been existing for some time. Yes, it is the first vaccine using that technology, no question about it. Other therapeutics have been using this technology, and they have been worked for a number of years. We did not need the vaccine, and that's why it wasn't developed in a way. But having said that, I think the mRNA technology allows you with really phenomenal speed. And that's why those two are the first ones of the block in a way to look at that data. And so, yes, that's probably the reason. Yes, it is the first time we will have mRNA vaccine. Very similar to HPV vaccine. Virus-like particles have never been used before for HPV. That is bound to be there. We just have to go by the data and trust the data when that comes out.
Okay.
There is question for Dr. Gedam sir from Dr. Tiwari. Selective consent to access health information and deny the same for the some other piece of it. Will that not be defeating the purpose of connecting the records in reaching the diagnosis?
So this is an excellent question actually. Now let us understand what we are trying to do. The National Digital Health Mission is converting the existing physical system into digital system, and that's the end of it. We are not changing any rules of the game, not any law. The question here pertains to something which is beyond the purview of digital health as well. How? If a person, let us say these computers and all don't exist, a patient comes to you with the files, then he even now comes to you with only those records which he is willing to show. So if let us say he may not understand that there are dependency, the way organs and various systems of the body interact with each other, and apparently a rash on skin may not be related with anything to do with art, and that's why he may miss out to tell the relevant history. And this is it is the skill of the doctor that we learn how do we extract the history. But the patient, I like to explain, let us say he is a case of depression or schizophrenia or some sexually transmitted disease. He may not want to reveal that when he goes to, say, orthopedic surgeon or an ophthalmologist, though they may be linked, which he is not aware. And this is happening even now. The whole purpose of keeping this element of consent here is that if we make all this accessible, it changes the existing rules of the games, which cannot be done unless Parliament passes some law. And this is a different kind of exercise that we doctors need to take up and explain the importance of getting complete access to medical records. But this is a legal problem rather than a technological problem. We don't want to wait to roll out the digital health till this larger issue is addressed. Whenever it is addressed, probably we will allow that in our digital ecosystem as well. As of now, doctors do not have right in India to forcibly and see as a matter of authority all the records that the patient may be having. He can simply tell you, okay, I lost it and I don't know, or he may simply tell the incorrect history. The good thing is that in such case, the liability, or in case the medical intervention goes wrong, the legal responsibility goes on the patient. And the advantage that this system will provide in such case is that this interaction will be documented. If the interaction is through telemedicine or some chat, it will be documented, and you will be in a position to tell, okay, I wanted to ask a leading question pertaining to a particular system, but he gave incorrect history leading to problem that that has occurred. So probably it will add to some legal safety value that doctors will have. I hope that answers the question. I am ready to explain it even further.
Thank you, sir. Dr. Khadse from Meghat, he has asked, in many tribal and remote areas of India, like Meghat, health data collection regarding malnutrition, it causes its must to prevent child death. So if any doctor wants to study on child health malnutrition, so can we give this data to him? Can we give data?
We can give data provided the rules are defined. As of now, the rules are not defined. We are in a preliminary stage because we want to give data to promote genuine public research. And we don't want to give data in which some, let us say, some insurance companies comes forward to decide the rate of insurance premium so that they can make more money. That we don't want to happen. So deciding the rules will be very critical in this case, and the data we definitely want to use for overall public health purpose, but not for commercial purpose. And it will take some time before we decide these rules. And even if the rules are decided, the data will be used in anonymized manner. So the identity of the patient will not be revealed, and that care we are taking forward. I hope that answers the question.
Yes, sir. Sir, can it help it to develop medical tourism?
Certainly, you can imagine a scenario in which there are countries or some areas which do not have doctors, but the patients have capacity to pay. A rich person in Bihar, for example, or rich persons in Middle East, where number of doctors, a particular country where number of doctors may not be that many, or in some African country, or even those countries where the waiting list is very high. So you can be able to make yourself available electronically. So this is an additional element of electronic medical tourism which will come. I may also like to say this can be specifically a good revenue earner for India as a whole, because we are the only country who provides, who has a skill set in yoga or Ayurveda and these kind of things. But we also have at one end situation where the facilities are very poor. but top class hospitals in bigger cities where a lot of foreigners come because the waiting list and cost in their country are preventive. And I think that is going to open floodgates of medical tourism in this sector.
Yes. I think we will conclude this session. Thank you. One more lecture is there. Before that, as we are shifting more digitally and by this National Digital Health Mission, present e-memento to Dr. Praveen Gedam sir. Let's be again digital in memento, giving memento also. Thank you very much, Dr. Praveen Gedam sir, for elaborating very widely on NDHM and giving, making us informative about the future plans. Thank you very much, sir.
Thank you.
Thank you, sir.
Okay, before moving on to the next talk, we have Dr. Virupaksha Joshi, who is a senior radiologist at Ashwini Hospital, Solapur. He will be talking to us with a small video about the CT score in COVID pneumonia. Dr. Joshi, sir, please.
Hello, very good evening to all. I thank the organizers for giving me an impromptu opportunity to speak on the CT Severity Score Index. Am I audible? Yeah. Yeah. What happened was when the pandemic broke out in China, the city of Wuhan, for diagnosis of the lung infections, they used to depend mostly on the chest radiographs. As the pandemic progressed, and the same thing used to be done in the Italy, Spain, and other European countries. Later, they realized that the high resolution CT scan has got a very important role to play in the diagnosis, not only the diagnosis, in assessing how severe actually the lung involvement is. And what happened was very quickly, many scientists all over the world came together and they have devised a score system to decide whether, first of all, whether a patient has got a COVID pneumonia or not, number one. And if the patient has COVID pneumonia, what is the severity of it? Because the severity thing came out because most of the times whenever a patient is told by the doctor, by his pulmonologist that you are RT-PCR positive and you have got a COVID pneumonia, the first thing the relatives, the closed ones ask is how severe the disease is. Is he going to live? Is he going to, how, that is the questions that come to their mind. So to keep this in mind, they have devised a score system. And we are going to play a short video to how we arrive at that score system. Please, this is a short video of 10 minutes. Please listen to the video. After that, if there are any questions, I'm happy to take that. Thank you.
Hi, welcome back everyone. Today let us see the CT severity score of COVID-19 on chest imaging. I would like to thank Dr. Priyan for making it a simplified PowerPoint for this CT severity score. So before going to CT severity score, what is CORADS? CORADS is a categorical assessment scheme for reporting of CT chest patients of COVID-19. And it represents only the level of suspicion, but not the severity of COVID-19 infection. So, for example, if CORADS level is 5, it indicates that there is very high chance of COVID-19 infection, but it does not indicate the severity. So, this is the CORADS scoring system, which is very simple. No findings, that is normal CT chest, low suspicion, intermediate suspicion, high and very high suspicion, which is nothing but typical COVID-19 chest imaging findings. And when the patient is PCR positive, then we label it as CORADS 6. Now let us see what is CT severity score. Before going to CT severity score, I wanted to show you one important pitfall. So if you see these small opacities along the posterior aspect but not along the anterior aspects, don't think as these as ground glass opacities. So this is nothing but the gravitational opacities which normally are present in most of the patients, which should not be confused with the ground glass opacities. So these are the classic confluent ground glass opacities. You can see peripheral location involving the anterior as well as posterior aspects of the bilateral lung fields. So always remember this pitfall. With these opacities should not be confused with the ground glassing. So let us see what is CT severity score. So we know already about the right and left lungs, and each lung is divided into three, right lung into three and left lung into two lobes. So each lobe is given a score of 1 to 5 based on the lung involvement. So the total score comes to 25. So what is the criteria? If the lobe involvement is 5% or less than 5%, we give the score of 1. If it is 5 to 25%, score of 2. 25 to 50% of involvement, it is score of 3. 50 to 75% involvement is score of 4. And if it is more than 75%, then we give a score of 5. So for example, the score 5 means that the lobe is more than 75% involved by the COVID-19 infection. So this is the classification of CT severity score, how indicates the severity of CT chest infection. So it can be classified like mild, moderate and severe based on the scoring system. If the entire score is less than 8, it is mild. 9 to 15, it is moderate severity. And if the score is more than 15, the severity score is severe. Here you can see one extensive peripheral ground glassing and even consolidation involving the bilateral upper and lower lobe segments and right middle lobe segments as well. So when this comes to report, this is how we should prepare a box for right upper lobe, middle lobe and lower lobe, and look for the involvement of each lobar involvement, that is 25 to 50 or less than 5% or 75 to 100%, and score each lobe separately and add it. The final score comes to this CT severity score, that is 15 out of 25 in the previous example. So what we are going to give in the impression is the features are suggestive of atypical viral pneumonia, that is CORADS 5. Once we have all the classic features of COVID-19 infection, and the CT severity score is 15 out of 25 and it is of moderate severity. So this is as simple as that. Just we need to divide it into lobes involvement, percentage of involvement and score assigned to that particular percentage. Then once we add up all the entire score of all the lobes, then we get the entire CT severity score. Thank you all. Hi, welcome back everyone.
So when this particular scoring system became very rampantly used by radiologists all over the country, it so happened that sometimes even the patients' relatives themselves used to come to our CT department. Then they used to demand, please tell us what is the CT score. So this much popularity this particular scoring system has gained in such a short time. So are there any questions? I'll be happy to take.
Yeah, Dr. Joshi, there is one question from viewers.
Yeah.
That is, how much time it takes CT to come to normal?
Actually, it is not a very easy question to answer, because actually it depends on the immune response of the patient. If the patient's immune response is too strong, and then what happens is fibrosis develops in the lungs. So the changes of fibrosis, they remain almost permanently. This is just like a scar outside. Whereas if the immune response is just adequate, most of the lesions, they resolve on their own. And if you repeat a CT scan after a couple of weeks, after he's declared, say, COVID negative, and probably you may not see any trace of the disease in his lungs.
Okay.
There is a question from Dr. Sriram. It is seen that person who have COVID lung fibrosis are resistant to COVID-19 infection. Is it true? COPD, sorry. Who have COPD, lung fibrosis, are resistant to COVID-19 infection. Is it true? And if yes, why?
Yeah, actually it is true. Why it is so, nobody knows, but it's an observation that most of the patients with the chronic lung disease, chronic obstructive lung disease, what we call as a chronic, they are somewhat spared by the severity of the more severe form of the infection.
Okay. So which patients are more susceptible for CT changes? Is there any data?
It's not like in our short experience, we have seen that there are some patients who are just mildly symptomatic, just say fever for 1 or 2 days, some dry cough and little bit anosmia. They come for a CT scan, and many times they are first time the CT is normal. But after some time, we realize as the days goes by, they become more and more symptomatic. Their SpO2 starts going down. And there, when CT is reported, we'll see more severe form of the chest disease, like a CT score of say 8, 9, or 10 out of 25. We have seen this also in our short experience in our department.
Dr. Umakant Karmakar is asking, is post-COVID lung fibrosis irreversible?
Yes. Some of the fibrosis is irreversible. The lung becomes like a rubber. And it depends on how much lung tissue is actually not available for oxygen exchange. That is will decide how severely the patient will be affected by the fibrosis. But it is true that the fibrosis is irreversible. It is just like any other lung fibrosis. For example, pneumogoniosis. Patients who are exposed to asbestos infection, their fibrosis remains in the lung forever. Probably now we are too early for us to say this. Maybe because we are still in the process. As the time goes by, probably more and more CT will be done in the due course, and probably we'll be able to answer this question better.
There is one question. Yeah. There is one question from Nilangekar. That is, what is the ideal time for doing CT in COVID patients?
An ideal time will be to say 3 to 4 days after the onset of the symptoms, because that is when the lung changes start appearing. Say, for example, today if the patient comes to a fever OPD with fever and cough, immediately if you do a CT, probably that CT will be normal. Do a CT 3-4 days after that, you may see changes, and it may help you to decide whether this patient needs a hospitalization or a home quarantine will do for him. So ideal time is 3 to 4 days after the onset of the symptoms.
Okay. Any relation with SpO2? That is, should we match this ideal time for with SpO2?
No, there is no correlation between SpO2 and the CT score at all.
Yeah.
It should be done on the bedside by the treating pulmonologist, depending on the SpO2.
Dhananjay Vaure is asking, what is the cause of post-COVID pleural effusion and pneumothorax?
Usually, pleural effusion is practically not there in COVID pneumonia. That is one very important finding that we have noticed. In fact, in a patient with a COVID pneumonia, if we see pleural effusion, we have a second thought, like whether this is really COVID pneumonia or we are dealing with something else, some other non-COVID infections like virus or some bacterial pneumonias. So pleural effusion is not a feature of COVID pneumonia. So I think you should reconsider your diagnosis if you see pleural effusion.
Thank you.
Sir, what is the correlation between RT-PCR positivity and HRCT positivity?
I don't have that experience. Many times I have noticed, I can talk about the rapid antigen test. Many times patients come with rapid antigen test positive, but their CT is absolutely normal. And the reverse is also true. Many times we see changes on the CT scan, and I'm told that their RAT is negative. But I don't have the similar experience with RT-PCR tests so far.
Thank you very much, sir.
Thank you.
Now we will move to next speech by Dr. Sandeep Bhajibakre. We all know that doctors are the cream of society, and
we now move on to the last talk for today's session by Dr. Sandeep Bhajibakre, who is an IPS officer. He is the DCP of Traffic in Mumbai. He has done his MBBS from our very own VM Medical College, Solapur. He has implemented various programs in his area at Gadchiroli, like Operation Parakram, Operation Sarvodaya, and Janajagran, Melavas. He has controlled the communally sensitive situation at Aurangabad during the Ganpati festival in 2010. We are very, very pleased to invite Dr. Sandeep Bhaji Bakre to present his talk.
Hello, friends, my seniors, sirs, my junior colleagues, and my friends. I'm very happy to join medical fraternity after few gaps. I used to meet and share my experiences, thoughts with my medical fraternities often with through some seminars, webinars, or some kind of physically attending conferences. As a introductory part, it was told I am student of VM Medical College Solapur, and a few of my batchmates are attending this seminar. I'm very happy to see you all and with you people. The topic allotted to me is multidimensional medicals. In fact, when I observe many of the college students and all, I found basically medicos very much multidimensional in themselves. As you know, we have to be. And when few doctors from our medical fraternity joins other streams also, as one of the panelists earlier rightly said, they are the cream of the societies, one of the very few chosen few people which are very good at studies, and those are sincere. And when one is very good at studies, homework, and is sincere, wherever and whichever section of the society or career he enters, so he has to shine into that. And many of the examples are in front of me, uh, as like my earlier speaker, Dr. Praveen Gedam sir, and many of you also know. So when I have very I was told that why I left medical and went to some other field or something like that, that to share with you. Since beginning, I had intention of joining administrative services. That was the reason. And I'm very happy that my graduation is a medical sciences, because that has helped me a lot while pursuing my career in police department. I would like to share a few of the examples. I was in Gadchiroli as sub-divisional police officer. As you know, Gadchiroli is a Naxal infested area, and often there are Naxal encounters, and injured Jawans are brought to the Gadchiroli police headquarters, and they were treated. In the very few experiences, I found that it was a mess. So many number of Jawans coming to the hospital, and everybody is running here and there. I thought that there can be something can be done to this. So first of all, I documented all the health records of my all Gadchiroli Jawans, blood grouping and everything. Then I observed that many of the losses of lives are because of excessive blood loss due to gunshot injuries. Then I searched, then I spoke to my colleagues, my seniors, that what can be done for that. Then I came across a powder called quick clot, that when that can be carried with the Jawan, and if there is a gunshot injury, then that can be just applied to the wound, and it immediately clots, any blood clot is found, and even bigger wounds are that blood loss can be stopped. So this powder proved lifesaver for Gadchiroli Jawans. Then this documentation again helped with the minor observation that we are being taught during our clinics and all. I found that when the injured person is brought, then uh, crossing and matching and cross matching is done, and then the blood bag is removed, and it has to be for the room, it has to come to room temperature, and then it is applied. Then I thought that when documentation was done, so whenever I come across a news that there is an encounter and injured Jawans are brought. So with the help of my record, I could find out that what is the blood group, and I could assess that what is the loss of blood. So immediately 2, 3, 4 bags I could took out and let it be at a room temperature. And on the before coming to the casualty table only, this matching and cross matching is done. And immediately when Jawan comes to the casualty table, that transfusion started. So this again saved many of the lives of the Jawan. One incident I remember that one of the Jawans was injured. He has a splinter in his head, and I came across them. There was no communication. Then I had to communicate through our wireless system, and I had designed a special first aid kit for especially this kind of incidences. And with the help of that, it was night time, and with the help of that first aid kit, I uh, I could I could treat, or I could make the patient survive for a few hours. But at 2, 3 o'clock in the night, patient got worsening. Then again, I called some of my seniors, neurosurgeon and some trauma specialist, and I was into conference call with them, and head load, different whatever I have medicines at that time. With the help of that, I treated the patient, and in the morning 6 o'clock the helicopter was coming, and with the help of chopper the Jawan was to be lifted to Nagpur. So when till 6 o'clock I could hold the patient. Then 6 o'clock helicopter came, and he was flight to Nagpur. But the Jawan was insisting that he has to be stopped at Gadchiroli. I was at Gadchiroli. Jawan was lifted from some interior part of the Gadchiroli, and it was to be transported to Nagpur. But with the then pilot contacted our superintendent of police over there, and he said, "Ki Jawan wanted to land in Gadchiroli for a few minutes." Then he was not allowed. But again, when he insisted that he was landed in Gadchiroli, his whole family and we were standing on the ground to see what happened and why he wanted to land. Then the helicopter landed. The Jawan just landed down. He hurriedly came to, not to family, but to me. He hugged me and he said, Ki, because of you, I was survived for the whole night. And I know I'm not going to die after that when I survived throughout the whole night. So everybody was in tears. And, these are some of the fulfilling moments that a medico only can understand into whenever, whichever field he has. So it was a very satisfying and fulfilling moment in my life, and I cherish this moment. I will cherish this moment for whole of my life, and I felt very happy that my graduation is medical, and because of that I could save few Jawan. One more interesting example of being medico and into this police service that came to be. I was in Aurangabad, and one of the very much dreaded criminal called Imran Mehndi. He was one of the important gang members of Dawood Ibrahim gang. So he left Mumbai and he was in Aurangabad. He had 14 murder cases onto his name and supposed to be very dreaded criminal in Aurangabad. In Aurangabad, he very covertly he was showing that he's not doing any illegal thing. We were having watch on this, but he was overtly he was very, uh, I mean, sober kind of business he was doing, some washing, car washing business. Uh, After 1.5 years in Aurangabad, I came across a case of kidnapping of one corporator. And during investigation of that kidnapping of that corporator, uh, through my intelligence and my khabri, I found the name of Imran Mehndi. But he was all alone, living quietly, very socially good life and all. So he was living in some very good area. So, So in the night when myself went to catch him, I along with a few men went to his home. I knocked the door and from inside he said, "Who is this?" Then I said, "It's police. ACP Bhajivakar is there." So he said, "Yes, coming." So he like nothing happened. He came out. He came out and I just uh, uh, I just hold his hand and I said, "What happened? क्या हुआ इमरान?" तो वो बोलता है कि क्यों सर मुझे क्यों लेके जा रहे हो, मैंने क्या किया है? आई सेड तुमने कुछ नहीं किया है, चलो जरा पूछताछ करनी है. Then I just hold his hand and I checked his pulse. So although in appearing he was showing that nothing has happened from his face and all, he is very calm and quiet. But when I checked his pulse, it was very high volume and it was a tachycardia. So I immediately understand what is there. So I asked Imran, "क्यों इमरान कुछ किया है क्या तुमने?" So he says, "No sir, मैंने तो कुछ नहीं किया है." तो मैंने बोला, "तुम्हारी नब्ज क्यों इतनी फड़फड़ा रही है?" तो बोलता है, "कुछ नहीं सर, अभी तो आपने नींद से उठाया." मैंने बोला, "नींद में तो नब्ज स्लो हो जाती है." तो नहीं, कुछ नहीं किया सर मैंने, लेकिन मैं समझ गया था उसने क्या किया है क्या नहीं किया है. मेरा it was my apprehension that he might be there, and with the help of his pulse and his every behavior, I thought and I came to conclusion that yes, something is there. So when I interrogated, and in the light of this, when I interrogated, I found 5 murders. I found no less than 5 murders, total 5 murders over the period of 1.5 years. He has contract killer. He took some ransom, and for that he killed 5 people from Aurangabad and buried them. So after 1.5 years, I could found the 5 murders came to the light, and my this pulse checking and all that was that leaked somewhere, and that was very good media appreciation for that. People used to say कानून के हाथ लंबे होते हैं, 2 साल के बाद तो पकड़ा ही गया, लेकिन कानून के हाथ दूसरे के हाथ के पल्स भी चेक करते हैं. So that was a funny part of the story, but this was again a very fulfilling and satisfying moment. So there was one patient lying after an accident, so I gave him CPR, and I rushed him to the hospital when I was in Aurangabad. So that was again uh, this type of incidences help you build your image, and that image helps you containing the law and order, solving the issues. And I found that because of this image, when person came across, yes, Dr. Sandeep Bajivakar, so people think that yes, he's a intelligent and very uh, from intelligentsia community, so that help you understand the people. Again, the knowledge we get during our medical courses, psychiatry, doctor patient relationship, understanding of the body language. So all these type of things help you understand things, and by that maintaining your career and fulfilling into that. So this is very fulfilling and satisfying, that when the medico enter into the another field, so he applies his knowledge. We are shown, we are taught that first inspect, then palpate and all. So these all steps. So these basic knowledge you get, these understanding you get, these all these type of methodology, I would say, methodology that you get, it's a very, very important and satisfying and fulfilling to your thing. I have come across many of the seniors who are senior IPS officers and all. So they also look up to you as a very, very, they treat you with a respect. And uh, and again, one thing that we medicos do, that we have a habit of studying voluminous subjects, big books and all. So whatever big file that you come across, so you can just go through, and with the your earlier experience of understanding bigger books and all, so that helps you to understand very easily. So many of the seniors that I came across have treated me very well. As you know, excuse me, some call was there. So many of the seniors I came across, I found that they also wanted to be medicos. They undertook PMT for 1, 2, 3 attempts, but couldn't, and then entered into IPS. So they find you very good, intelligent person. So it is very satisfying that by your only degree or a prefix doctor in front of you gives you some height, uh, gives you some height of or some kind of a launch pad into that. So you must understand, many medicos entering into different type of fields have I mean a number of fields. There are artists, there are sports people, there are number of people into administration. They are doing absolutely well. uh, you must have been knowing that during this pandemic period, many of the doctors are given very important portfolios. Few commissioners of corporations were specifically appointed doctors as their commissioners. So definitely, these multidimensional medicos, when I enter into different fields, so they definitely shine and earn a name to the medical field. I have come across number of people who have, who have entered into different field and failed. I have not come across any of such person. Once a medico, always a medico. Whenever I feel that I entered into different field, but whenever I come across my friends and colleagues, even seniors, so that is again, I mean, entering into my own older area. So this is a very uh, important. And uh, whenever medical person enters into different field, he has definitely number of, I'm coming across few questions. You can you can you can I mean you can interact with me on web also. If panelists or administrators can provide this facility, I'm fine with that. uh, I I saw the contents of today's menu, and even whole of the seminar. I found it very interesting. I'm thankful to the IMA and organizing secretary and organizing committee. Marriages, time of marriages, then sexual life of medicos, then parenting, even grandparenting. So this shows that how multidimensional medico is. And uh, this is again, you included those people also who have left the medical field, but nevertheless, although I have, or some of me have entered into different fields, so again he remains still medico. I keep in touch with my medicos, my medical friends. During this pandemic period, only few departments of the government were working. One of the doctors, then your safai karmachari, police. So I was again a doctor and police. So to contain, earlier it was outbreak in Mumbai only, since international airport is there. So initially only policemen were much of the patients. So policemen were infected on a large basis. So my seniors were always taking my opinion. We created a facility for medico, policemen for taking care of COVID center and all. And I was very much aggressive for protection of policemen since they were exposed much. So we procured N95 masks, even PPE initially. Then later it was found that PPE is quite cumbersome for using field officers like police to wear and work in a work in a hot environment. PPE was, but still we could deduce some kind of protective shields, PPE and masks and all. So that again try to contain the spread of virus to the policemen. So I mean, when policeman enters into police or whatever other, definitely he applies his knowledge and methodology to the to that different fraternity, and I find it very satisfying and important. If there are some questions, I can take on questions.
Thank you very much, Dr. Sandeep Bhajibakre. Really, we are very happy to have a dashing doctor in this on this platform, and that too from Solapur. Again, we are proud of you. Your speech was very interesting, and it was very nice to listen the application of medical services to save Jawan, to save police, and to help in your investigations. Really, we heard it, and we it was very fascinating to listen all these things. Really speaking, how do you feel by heart, whether you are medico or you are police? By heart.
Definitely, I'm a medico at my heart, and it's my mother. I mean, I studied medical first, and later I entered into police. I should be honest to my colleagues and my fraternity. Uh, because when you do some kind of administrative career, you never know whether you are going to be into IAS or IPS or IAS or IPS, or so few marks here and there can land you into completely different services, revenue services or something like that. So definitely I'm medico by heart.
Thank you. And one more related to this only, when there is a question of death and save. So as a medico, do you feel to save the person in front of you, or as a police, you feel to kill the or punish the person in front of you?
See, you have raised a very, very important and very serious question, that it's a duty of a medical person to save a life. And secondly, on the contrary, it is not exactly a reverse, that to kill a person is a duty of police officer. Again, police is again, you must have known our this Bridvakya ki Sadrakshanaaya Khal Nigrahanaaya. So Khal Nigrahanaaya, that is there, but Sadrakshanaaya Hamesha. So question is ki I would like to take a few minutes regarding this. To kill a person in India legally, what you have to do, how to kill a person legally. You must be knowing that there are more than 100 countries in the world which don't have capital punishment. They don't hang the person, they don't kill. Whatever is the offense, person might have killed 1,000 people, but they don't kill him because of different reasons that I don't go into. But which few countries have capital punishment, but for that matter, Honorable Supreme Court has said that the offense should be rarest and the rare. Offense should be rarest and the rare. Again, when the offense is rarest and the rare, that means serious offense like killing somebody or very brutal killing or something like that. Still, the person has right to defend himself. He's arrested by the police. He's charge sheeted. He's given full chance of defense. You might be remembering the case of Kasab. He was again kept 1.5 more than that year. Then whole trial was there. He was given a lawyer. If person is not in a position to appoint lawyer, then government appoints a lawyer. Then it is said that capital punishment can be appointed by no less than at least sessions court. Honorable session court, no court less than that can award capital punishment. And the act says that this capital punishment has to be confirmed by default by Honorable High Court. Then still, I mean, person has to apply to the High Court. Then again, he has a remedy to go to Supreme Court and all. So after all this legal procedure and exhaust of mercy petition and review mercy petition to the Honorable, His Excellency President of India, the person can be killed. But imagine a policeman standing, a mob is there, it got violent, and that warranted firing, and policeman takes out a gun and fires. See, by firing, if somebody gets killed, then policeman is never tried also. It's a part of a duty, and policeman is set free. Policeman is set free, not even tried, not even offense is arrested, nothing. But see, the policeman at that time having how many responsibilities? If person has to be hanged, then everybody knows that Kasab has killed so many people. Still, he whole legal procedure has to follow. Here, a policeman stands, law and order is there, some violence is there, and he takes out gun and fires. That means, and he is never tried. That means you are allowed legally to kill somebody. Then what type of powers you are using at that time? You are using power of, policeman, then defense lawyer, prosecuting lawyer, judges, Supreme Court, and even we can say Honorable His Excellency President of India, who has power to pardon somebody when mercy petition comes to him. That means it is enormous power that is vested with the police. And when the power is enormous, it has to be exercised very, very judiciously in a very, very sparingly manner. So definitely either a medico or a policeman, there should be maximum effort to save the lives. And I will say one can kill a person to save. If you are going to save hundreds of people, then only you should kill one person. That I understand even by your question.
Hello. This question is for both Dr. Gedam sir and Dr. Sandeep Bhajivakre. Why did you choose the line of UPSC other than appearing for PG exam? Any specific reason? When you told already you were having some fascination of police. Any specific reason for both, sir?
Gedam sir will answer first.
No, he is not there actually.
Okay, fine. So as Gedam sir is not, I will say that. Am I audible?
Yes.
Yes, sir.
Yeah.
I will say that I didn't appear PG medical exam because simply that I thought I would not get anything, not even diploma, because I exhausted myself during my medical undergraduate studies only. I will honestly tell that I exhausted myself during my third exam, and I found my MPSC UPSC exams quite easier than third exam.
That's great. There is one question for Dr. Savaleshwar. Is he there online?
No.
Dr. Sandeep, I would like to ask you how to go ahead after MBBS for this. Is it as we are going through all the examinations, PG examination, PG NEET like this, what are the steps exact, in short, what are the exact steps to go for these services?
Many of the people know that these exams are conducted in three steps: preliminary, mains, and interview. Preliminary exams are conducted generally in May and June, mains exam during October and November, and interview in the March or April. So you have to appear, notification is there, and you have to appear for the prelims. Prelims is multiple choice questions, two papers, and in the mains, you have to choose one optional subject and general studies, two papers, and you have to write one essay. So this is a roughly pattern of the exam. So medicos preparing for PG, they will find the first part, that is MCQs, because they are much familiar with that. So this first part is a multiple choice question, so that might be quite familiar with the medicals since they are preparing for the PG and all these type of exams. Second type is a bit descriptive and this type of paper. You have to choose one optional subject and general studies, two papers, and essay. And after that, you appear for the interview. These are the roughly, and then you get merit, and you have to give preference order again, like any other PG medical or medical examination. Then you choose for IS, IPS, and other type of exams.
Nowadays, many of the medicos, they are found to be entering on UPSC side or sometimes even MPSC side. So the only question in their mind is, after getting selected in those posts, some higher posts, what is their fate? Means, is it better than doing medical practice? Means, what are the problems that you may be facing? This is a question that is almost many of the medicos, while choosing their career as UPSC, they do have.
See, something is better or not. So again, it's a question of your personality suiting to that. You know, few people might find their job interesting. Many of the people saying that I'm not happy with my job. So that is there with doctors and few people entering the administrative services also. So what is better? So this is like, I mean, if somebody likes blue shirt and somebody likes red shirt, so there is nothing that if somebody likes blue shirt, that means that pink shirt or red shirt is not good or something like that. It's a question of what suits you. So if some doctor thinks that he may he likes administrative careers, then that is fine. So question is, what is my experience when I entered into administrative services and all? So it is quite satisfactory. I'm happy with my services, because earlier, long hours of practice, then doctors also have to get up anytime when patient comes and emergency comes and all. So same is with the police. So many people find these type of things very cumbersome and problematic, that we have to get up at any time and long hours of your duties and all. So I find okay with that. And when I am passionate about my service, I am happy with my policing and all. So I am happy with my policing, but I find doctors happy with their profession also. So it's not a question of what is better or something, like what suits you, that is very important thing.
Yeah. One good question from one of the doctors, that is, what is your advice to IMA for having good relation with police? Have any some joint activity for having good relations? What we should do?
Okay. So no, it was very easy, as I was a doctor, and whenever whichever city I went, So few doctor colleagues and IMA over there, say for example Aurangabad or Thane, we have conducted so many so many uh, seminars or few projects that are helpful to the police as well as society. So uh, so what we can so I was a bridge between police and this thing. So I mean, police are also, with my experience I can tell, eager with connecting with the IMA and all, because we have a number of things to do with doctors, medical officers, your postmortems and number of other injury reports and all. So doctors, policeman is very happy with connecting IMA. Only thing is who will take initiative. So I mean, few what you say, panelist or your padadikari can bridge this gap and approach to police, or this can be done. I mean, police is very happy to work with IMA. Police is very happy to work with IMA. We have organized number of blood donation camps, few testing facilities for policemen, and this will create goodwill. This creates a goodwill, so that helps, when some kind of law and order problem is there. There I was invited for one seminar for the attacks on doctors. So if we have a good relation with policemen and all, so things becomes easier. Although they are duty bound to do whatever is there by law to do when there is attack on doctor, but this goodwill helps you get prompt service, and things gets relatively easier.
Yes, sir. Thank you very much. We as IMA also are very happy to work with police and for community to keep peace and order, law and order. As you have uttered the word attack, I would like to ask you the expert tips, as there are of incidences about violence against doctors. So we are worried very much about this. And can you give some expert tips to avoid these violences against, especially small nursing homes, OPDs? We are facing many times these violences. Please.
Definitely. See, thing is, we have to see the things in totality. In a sense, when I say in totality, what I mean? I mean, if you are limited, okay, so you find that these are some kind of aggressive people, all the way talking about what is the bill and this thing and all. So you should, as a doctor, for the diagnosis, you understand the signs and symptoms. So these signs and symptoms, the patient is getting impatient, and there is something going to be wrong. So these signs has to be identified. Secondly, as our principle is that prevention is better than cure. What I say is, when patient enters, you have to establish a dialogue. Gone are the days that doctors were viewed as gods, and they will be whatever bill they will give and whatever service they will give, and people will accept that. People are, when we are in a transitional phase of history, we are neither developed countries nor undeveloped countries. So we are a developing country. In this transition phase, people are aware of their rights but not duties. So this happens everywhere in the world. For that matter, you have to establish a dialogue that these are the treatment. I say I had observed in few corporate hospitals that they have separate sessions of counseling, or you say discussion. They they again charge separately for that. That's a different matter. But if you are a single hospital or a multi-specialty hospital, still, madam, you are saying something.
So that's why I said small hospitals. That's why I said small hospitals like us.
But, okay, fine. Although a small hospital or a single doctor hospital or a few doctors coming and establishing hospital, still you have to establish a dialogue that these are the treatment. and the expenses might be this much. There are two major reasons for attack on hospitals and doctors. One is death, and second one is bill. So I will talk about bill first and later on this death and all. So when you establish dialogue and tell him that this will be this much maybe the stay, and this much maybe the bill, this can be more than that, but you be prepared for that, and have a compassionate have a compassion with the people, because that has to be there with doctor. That person is coming to you with some kind of trauma, accident, or some kind of major disease and all, so you have to be compassionate, but at the same time we have to look after our economy also. So we have to pay bills and everything, taxes and all. So for that matter, this thing, that counseling and discussing and making the people and relatives aware about the situation, that this might go long. So take out a separate few minutes for that and make a counseling. This is one thing. Second thing, if the person immediate death and all these things is there, I have observed that some loose talking of your staff has created a problem. Doctor might be a compassionate and very nicely talking, but your nursing staff and other staff, so these loose talking, आता ते काय जगतंय का, काय करायचं त्याचं, ते उगाचच आता if some of your staff is not happy with you, how he will talk, he will say, ते काय आता उगा लावून ठेवले त्याला व्हेंटिलेटरवर, ते काय जगणार आहे का, उगा बिल वाढवायसाठी सुरू केलं. So few of such things creates a very bad impression, and this heat goes up, and if the patient dies, and then there is a law and order. So for that matter, you have to train your staff also that this loose talking should be avoided as far as possible, and you should counsel the patient this thing. And after all, if something goes wrong, I will not say that doctor should be at loss, but if you find that things are going to be out of hand, and window panes of your hospital are going to be broken, mob is there and all, so be patient at that time. There are ways and means to recover. There are number of other ways that we can file civil suit or something like that. But for that matter, for saving, there is a bad image, there is newspaper media reporting and all, this was stone pelted and all. To save that, we can hold on till now, because this gives very bad image that body was not handed over to the relatives because they didn't pay the bill and all. Although I can understand both doctors and these patients this thing, but to save the face, this is a professional hazard, we can say. If we have a grocery store, and if the tin of oil spills, तेलाचा डबा जर सांडला, तर आता काय करणार, कुणाला जबाबदार धरणार, एखाद्या वेळेला सांडू शकतो. हे जसं प्रोफेशनल हजार्ड दुसऱ्या म्हणजे प्रोफेशन मध्ये असतं, किराणा दुकानामध्ये सुद्धा असतं, तसं आपलं एखादं बिल असं जाऊ शकतं, असं आपण सुद्धा मनाची तयारी ठेवली पाहिजे. Moreover, as I said, in totality, so you have to look for the signs and symptoms, you have to counsel the patient, avoid loose talking by the staff and yourself also, and again having a good relation. But at the same time, you should be very firm also, because it's relatives versus doctor, so there is a psychological comparison between them. If they found that doctor and administration is can be pressed, so they become aggressive. So you should be firm also at that time. Whatever you do, I will do whatever legal is there. So you should have that much firmness while you talk and deal with the patients also. So I think with these tips, one should find it easy to deal with such kind of incidences.
Yes, very apt and very kind instructions you have given, sir, so that we can have safe practices. Thank you, sir.
Yeah. Well, Now this session is over. One sentence that I like from you as a medico, that once a medico, it is always medico. That is the sentence that we all of us would always like to listen from such persons. Fine. Now this being a session of online, your felicitation is being done online. I request.
Thank you. I would like to thank you. I am a Solapur. I am a Maharashtra organizing committee secretary, president, all other members, and my friends, colleagues, senior sirs, and my junior friends. It was very happy to be connected to you. I am anytime available to you for any kind of police related matter, or in general, if you find myself that I can be of any of use to me, I'm very happy to, I will not say help, I will be very happy to be with you. Thank you. Thank you so much.
Thank you. Here we present you, sir, a memento.
Thank you. Thank you so much.
We now come to the concluding few moments of this extremely interesting and very, very interactive session. Before we conclude, I would request Dr. Milind Shah sir to please felicitate the chairpersons for today's session, Dr. Jyoti Chidgupkar and Dr. Sudeep Sarda sir. Thank you, sir. Before we conclude, I would again like to humbly remind all the delegates that tomorrow morning we are going to start half an hour early for the virtual inauguration ceremony of formal inauguration of MASTACON 2020. So I request everyone to please log in at 8:30 instead of 9 a.m. We now close this session. Thank you one and all for attending.
Hello, madam. Just one more announcement. The link would be the same for all the delegates who has joined with today's link.
Yes, it would be the same link which would continue for all the 3 days.
Yes, yes.
Thank you.